our CME coordinator, and Jennifer Goodman, who manages our nursing CE credit. We welcome you to another program. The program this evening is going to provide 1.5 hours of Category 1 AMA CME for physicians and 1.5 hours of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern State CME Collaborative for physician Category 1 CME programs and accredited by the Virginia Nurses Association for nursing CE hours for continuing education programs. The program this evening was designed to promote the desirable physician attributes of patient-centered care utilizing evidence-based medicine. It's based on the tremendous public health issue of illicit drug and substance use and abuse in our communities. Dr. Holstedge, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships. There is no commercial support for this program this evening. It is supported by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology Nephrology Group, previously known as the Danville Urologic Nephrology Group, established this fund upon his retirement a number of years ago, and it has grown to provide support for speakers for continuing education for healthcare professionals in our community. At the end of the program this evening, you'll receive by email an evaluation form. That form requires you not only to answer about 7 questions about the program, but ask you to re-enter your full name and your email address. We ask you to please give us your full name, not a nickname or short name, since this is the name that will appear on your CME certificate. We also point out that question 4 asks, what changes will you be making in your practice based on what you learned through the program this evening? Excuse me, that question is for everyone on the call, not just the physicians. We all practice our skills within our scope of practice. So take a few minutes and answer the questions for us, if you will. This evaluation is very helpful to us in developing programs and in assessing how we do with the programs we present. We also will make available this evaluation sheet with a QR code that will appear in the chat box at the end of the program. You can access either way, either the email version or the one through the QR code. For Sovah Health medical residents, you do not have to keep up with your CME certificates. We inform your coordinators, Dara Johnson and Lori Galvez, and they track your participation. For nurse practitioners and nurses, in order for you to receive CE credit, you must complete an evaluation form. Otherwise, for everyone else on the call, the evaluation form is voluntary, but we do ask you, if you would, to take a few minutes and do it. It's so helpful to us. Each time we do a program, I like to make a specific point to thank Mary Kent and Jennifer Goodman for their help in our developing these programs. They do the majority of the work that allows us to gather and to have the programs on the internet for everyone. So it's a big thanks to both of them. Questions are encouraged. If you would, enter them in the chat. If you want to make a verbal question when the speaker asks you to do so, just click on the little raise your hand or speak up. Mary Kent will be monitoring the chat and will feed the questions to the speaker as they come in. I would tell you that if you do make a verbal question or comment, which you're welcome to do, once you finish talking, please mute your phone your phone or your device so we don't have feedback. And you're certainly welcome to ask as many questions or make as many comments as you would like to. Let me highlight the last 2 programs we'll be doing for this calendar year. Next week, next Thursday evening, Dr. Boland, who is a nephrology division member at the Wake Forest University School of Medicine in Winston-Salem, will be reviewing diabetic nephropathy and its treatment. I included this little picture just below her picture to remind everyone that diabetes mellitus is the cause of well over half of all starts on dialysis and renal replacement therapy. In other words, it is the major cause of end-stage renal disease in Virginia, as well as the nation, and it is to a great extent preventable. She'll be talking to you, though, about identifying patients with this early on and the multiple drug treatments we now have that can be beneficial to these patients. And then we're going to have Dr. Holstead come back again in 2 weeks, and he's going to talk to us about the appropriate care of an envenomated patient. That's things such as snake bites and spiders and things that, unfortunately, these things do happen, and it's a whole set of skill sets that you need to know about in caring for these patients. That leads us up to this evening's program, and I'm delighted to have Dr. Christopher Holstead back with us again. He's done programs for us in the past. He's traveled to Danville and done sessions with our residents as well as our providers. He is from the Midwest part of the country, growing up in Michigan, and he received his undergraduate degree from the Calvin Coolidge College in Grand Rapids, Michigan. This was followed by his MD at Wayne State University School of Medicine in Detroit, and then he completed emergency medicine residencies at the Michigan State University Butterworth Hospital program. He followed this with a fellowship in medical toxicology at Indiana, and then came to the University of Virginia, where he's been as a major tenured faculty member for a number of years. He has been extremely active there and has been personally responsible for developing their Center for Clinical Toxicology, which provides inpatient consult services as well as outpatient consult services for their patients. This is a huge program. They see over 500 consults a year within their inpatient group. He also, as the medical director and manager of the Blue Ridge Poison Center, which provides care for about 5 million citizens of Virginia. They handle something like 35,000 calls a year, covering 73 facilities. Then he's also in charge of the Department of Student Health and Wellness at the University of Virginia, overseeing medical services, counseling, disability services, as well as a wellness promotion and research activities for the students there. And then on top of all of that, he takes his turn as ER attending physicians in the ER at UVA. His work has been recognized by the university by his receiving the Thomas Jefferson Award, which is the highest university award given to those that exemplify Mr. Jefferson's principles and the mission of the university in character, work, and influence. His undergraduate college recognized him as a distinguished alumni, and he also was selected as a member of the Raven Society, which recognizes service and excellence in work at the University of Virginia, where he received the Ravens Award. It's a real pleasure to have him with us this evening. And Dr. Holstead, if you'll bring up your slides, you should knock mine off, and we'll begin. Thank you so much.
Dr. Moore, thank you for that very kind introduction. Can you see my slides?
Yes,
yeah, they just need to go into full screen.
Yep.
Look good.
How's that?
Try again. We're seeing the first and the second slide. There we go. Perfect.
Perfect. Thank you. No, it's great, everyone, to be with you tonight on a topic that impacts all of us. And as the director of the Blue Ridge Poison Center, we cover your territory, and I've worked with your hospital for some time, as Dr. Moore said, and it's been a pleasure to come and see you in person, and a pleasure to be here tonight to talk with you on this topic virtually. Interesting times in which we live, and that's what I'm going to try to highlight tonight, that it is exceedingly complex. I've been practicing medicine for over 30 years. Challenging times that we have. The internet's really opened Pandora's box. It's very easy to get various substances directly delivered to your home, much less to vape shops and other places. Very challenging time in regards to making sure our youth stay safe at this time, which is why I'm so integrally involved with the University of Virginia students. And in 2013, took over leadership of that area also, as we try to mitigate the mental health crisis, but also substance use, which constantly is a risk to them. and try to do best practices that hopefully can others in the country can exemplify too as we do research in that realm. With that, I got nothing to disclose. I'm happy to say that I'm not investing in any of these entities, and certainly there's a lot of people making money on substance use right now. The objectives tonight, I want to talk with you about the cannabis analogs. What exactly is going on since we've decriminalized cannabis, and where are we going in that area? The hallucinogenic agents are starting to creep up, and I want to explain why that is and some challenges that we have. The opiate epidemic, there's some improvement in regards to what we're seeing in deaths, how many calls we get to the poison center, but still the issue that's killing more of our population accidentally than anything that's out there. And I'll go through some of the changes that we're seeing in that arena. Counterfeit pills, we'll talk about briefly as a risk, especially I think to our youth, and then emerging substances, which is so quick. It's hard for me to keep up, and I do this for a living, and certainly hard for the general providers who are out there to be able to keep up on what's going on. I also want to talk about the urine drug screens, exceedingly important from my standpoint, both in my realm as in the adult and pediatric realms, as we start talking about managing patients who come with altered mental status, what may be causing that, and how the drug screens are exceedingly limited right now. I'm going to start with a case. Yeah, this kind of exemplifies the problem that we're seeing. So at 8:55 p.m., EMS gets a report of a 19-year-old university student who's found by his roommate markedly confused and wandering in the house, and 911 is called. On arrival to the emergency department, temperature's elevated at 39, heart rate's 145, blood pressure 150/90, and a respiratory rate of 22 breaths per minute. He's awake, but picking at things in the air as if there's something there. He's got confused speech, startles easily, reflexes are markedly increased. He has sustained ankle clonus. He has nystagmus. Pupils are seen to be dilated at 9 millimeters. No signs of trauma. Remainder of the examination is negative. It's templated. We have EPIC at the University of Virginia, and he received 5 milligrams IM of midazolam to allow the team to be able to do blood draws, put an intravenous line in, and do further testing. He had a head CAT scan because it wasn't clear what had happened. He had basic laboratory testing, which was normal, and an electrocardiogram that showed tachycardia, but no other abnormalities. Reevaluation a few hours later after the midazolam was given, his temperature had resolved and become normal. His heart rate dropped to 122. His blood pressure had dropped to 120/77, and respiratory rate was 18. He was calmer. He continued with hyperreflexia, clonus, and visual hallucinations, and was talking to people who are not present when our team was consulted. His initial urine drug immunoassay, these are the urine drug screens that are typically done at all the hospitals that we cover through the Poison Center, all 73, was positive for phencyclidine and negative for other substances screened. Confirmation testing, we're fortunate at the University of Virginia in that we have GC mass spec and other testing to do confirmation testing. It's really the gold standard, and that actually was negative. So we had a positive on a drug immunoassay, a negative on confirmation. And this is a classic case, demographic group, the signs and symptoms, and what the drug screens showed for someone who's using and misusing dextromethorphan. So dextromethorphan has serotonergic properties, causes hallucinations, causes your nervous system to be stimulated, gives you hyperreflexia, clonus, mydriasis. It gives a false positive for phencyclidine, and on confirmation testing will be negative. And this is just one example of many I could give of cases that come in where the screens actually can be misleading. We're also seeing a lot with screens, and again, I'll talk more about this, in toddlers who come in with altered mental status, get a very expensive workup, resolve within 24 to 48 hours, only to find that they had actually taken a substance accidentally and found that they had found. So new psychoactive substances, you're hearing a lot about this in the news, and that these are rapidly emerging. These substances are not necessarily new. They are new on the market, but they've been around, many of these, for some time. In fact, we're seeing substances popping up that we haven't seen since the 1960s in the US society significantly. They're also known as designer drugs. They're marketed as legal highs, and the reason they say they're legal is that either the United States federal government or the state government hasn't banned them, or they can't be detected on drug screens. And they're also marketed as research chemicals, with the companies claiming that these never were meant to be ingested by humans. So a lot of games being played, and I'll explain this a little bit more with some of the products that I'll show you here as the talk goes on. Now, you should all be aware, in 2013, the United Nations Office on Drug and Crime worldwide stated that the international drug control system was floundering for the first time since the 1960s, mainly because of the speed and creativity of the new psychoactive substances. And this came on the wings of both the synthetic cannabinoids, K2 and spice, as well as the bath salts. And the bath salts, which are synthetic cathinones, which are derived from khat, that comes from Saudi Arabia, the plains of Ethiopia, really were a wake-up call for us in the clinical toxicology realm. And at that time, we worked to get funding, and we actually have a full-time PhD in epidemiology who works with us, who's constantly monitoring our data from the Poison Center to assure we are following the trends and can put warnings out quickly to our state and federal government when we see new substances emerging. When you look at the new psychoactive substances, the categories that were broken down by the United Nations Office on Drug and Crime, the biggest category was stimulants. The second biggest was the synthetic cannabinoid receptor agonists, which I'll talk more about, classic hallucinogens, opioids, and others, including sedative hypnotics, which I won't talk about further other than to tell you that there are new novel benzodiazepines that are hitting the market that we're seeing in our testing too. We just submitted a paper that was accepted on bromazolam that we're seeing in samples. We also have a case series of neonates being born with bromazolam with withdrawal associated with that would not be depicted on your typical urine drug screens. And again, we're fortunate that we have advanced analytics right now to be able to test some of these children, including those who are neonates, on what exactly were they exposed to in utero. Now, some of you have heard me talk before. I've talked about this site. This is Irwit's Psychoactive Vaults. This has been around for decades. I've followed this for quite some time. It's actually very well done. And what you can see on this is they have a front page where if you want to do, for example, like the first case, dextromethorphan or DXM, I can click on that link. It'll take me to dextromethorphan. It'll tell me where I can buy it, what dose, that I can take Coricidin cough and cold tablets at 30 milligrams. How many of them should I take? And what kind of hallucinogenic pact would I want to get? There's chat rooms, the laws, it talks about drug screens. There's a whole host of things for each one of these. Now, if you look at this also, you can see on the bottom right, there's a place where you can click that says more. And I encourage you to go to this site. I also encourage you to click on the more, because it's page after page of over-the-counter, prescription pharmaceutical, herbal, plants, mushrooms, animals, and chemicals that are in industry that you can do for a psychoactive effect. Many of these I've actually never heard of and not seen in my practice. And I'm sometimes surprised at what I learn from some of my patients that I'll see in clinic on where they're getting these chemicals from and how they are using them and how they talk with others on chat rooms. And for those of you who are working in the pediatric realm or seeing young adults, I can tell you they are certainly savvy with these sites and be able to find these substances. And they're very well aware that the drug screens don't make many of these positive. And for you, also, if you think about this further, also makes me pretty nervous when I drive on the roads these days as to exactly what are the other drivers taking as they're coming down the road. Now, the poison centers, which I have a vested interest in that I have managed one for nearly 30 years. The National Poison Data System has been around since 2000. And at that time, we switched over from old bubble sheets to electronic. It's one of the oldest national data systems in the country. The nation's 55 poison centers upload every 4 minutes the data that's coming in. So if you have a call that comes into the poison center, you call us about a case at Danville, that is put into a system called Toxicol that has data that is uploaded and de-identified to this national data system that works with the CDC for public health surveillance. That is partly where we get some of the data very quickly when new substances come on the market. We can then depict what the clinical signs and symptoms are, especially the complications, and then work with legislators to get those off the market because of the danger they pose. It's only as good as the calls that come in. I encourage you to call us. It's always staffed by nurses or pharmacists who are trying to help in the community, both the public and the professionals, when it comes to these cases. There's also a change in Virginia in that there are now 2 instead of 3 poison centers that cover Virginia. There used to be a Northern Virginia poison center, the National Capital Poison Center, that closed. The Blue Ridge Poison Center at UVA, which I've managed for some time, and the Virginia Commonwealth University's Poison Center, you can see where the territories depicted that we cover. And I work very closely with John Downs, who's their director, to make sure that our data is shared and that we're following trends very closely for the Commonwealth. For example, THC edibles. Virginia decriminalized marijuana on July 1 of 2021. You can see based on our data for each year that we had a rapid rise of edibles in 2022. Our data doesn't tell us the prevalence of the use, but it tells us the trending of use. And what was most concerning with me, and what I was on the news quite a bit and talking to legislators about, was the number of toddlers that were getting these products, typically accidentally, though we did have some individuals. I had a grandmother who accidentally bought a product thinking it was candy, and she and her grandchild ate some. Both were hospitalized, and we've had a number of kids who've needed critical care attention, including at the University of Virginia, where these kids will get transferred to take so that we can take care of them. And we've had some who've had to go on life support. But you can see in the adult population, too, some of the complications that have occurred with these substances. In 2021, we started to raise the concern of Delta 8 THC based on the data that was coming into our centers. Delta 8 THC is actually part of the cannabis plant, very small amount, but then we were seeing products with purified that was synthetic. And we saw a lot of cases that were coming in. And some of you may have heard at around that time period, there's a 4-year-old in Northern Virginia who got into THC gummies containing Delta 8, ingested those, and instead of going to the hospital as was recommended, the mother put the child to bed, where the child subsequently died. And this caught the attention of the legislature to get those banned, and subsequent legislation came out talking about what could be put into products, not to make it look like candy, should be child resistant. Yet we're still seeing problems with many products that are out there within Virginia. Now, the cannabinoid receptors, are complex. As a toxicologist, I really follow the chemicals that we see and how the exposures impact various neurotransmitters. And the cannabinoid receptors really interact with many of our common neurotransmitters: acetylcholine, glutamate, GABA, epinephrine, dopamine, serotonin. CB1 is primarily located centrally. It's where the psychoactive symptoms are. And we certainly know the chronic complications with chronic use of these products, everything from decreased IQ, low attainment, We certainly are seeing more patients of cannabis-induced hyperemesis syndrome. There's a number of things that are out there right now that we're seeing more in the hospitals. Now, when you look at this, there's really three different categories of cannabinoid receptor agonists. Our own endogenous cannabinoid receptor agonists that modulate neurotransmitters, but we have synthetic cannabinoids, not derived from the plant, but that are made from various chemicals. When you hear about the synthetic cannabinoids, you'll hear different names really in three different categories. One is sometimes based on the researcher who developed them. JWH, for example, or John W. Huffman did work for the pharmaceutical industry, published how to synthesize these, but then they were abandoned for use in humans when they started to take a look at these chemicals. Much more potent, many of these, than delta-9 THC that is in the cannabis product. And the products you'll hear is like JWH12 as the 12th chemical that he developed based on small chemical modifications of the structures. Sometimes they're slang names. XLR11 we recently had at the University of Virginia. That is a slang name for rocket fuel. And then the real scientific names that people are starting to go to, the scientists and medically, actually try to spell out exactly what are their chemical structures. 5-FMD-MB Venica, for example, there have been outbreaks in the country with that product. Realize that the synthetic cannabinoids are changing routinely. Traditionally, we initially saw K2 and Spice in 2009. Those products are still out there. They have plant material. They're dusted with some of these chemicals. The packages stated they were incense, they weren't meant for human consumption, and yet everyone knew that they were actually meant to be smoked. They're meant to be rolled in a joint and smoked. And again, markedly potent. In some of these synthetic cannabinoids, we have seen psychotic breaks with some of our patients not returning back to normal. I had one really decimating case of a student who got one of these products and never returned to normal and ended up going to Western State. And then you have the phytocannabinoids, what's in the plant. And this gets to be challenging too in society because there's not just delta-9 THC. As I mentioned, there's also delta-8 THC, which is the market, but then there's other ones. There's THCP, THCV, there's delta O-acetate. There's a whole host of different chemicals that are in the plant. And when these come out, the producers state that these are natural. We've decriminalized, and these are natural products that are deriving from the plant, when in fact they're actually synthetic. And I think it's one of the challenges that we have right now with the vape shops that are selling many of these products. For example, I'm seeing a lot of Delta P now on the market. I won't show you too many chemical structures, but I do want to show you this because I think it's important. When you take a look at CBD, delta-9 THC, and delta-8 THC, all three of these have the same chemical formula and the same molecular weight. It's just bond changes. What's impressive to me as a toxicologist that I can take CBD and delta-9 THC, make a simple bonding change, and I can have dramatic impacts on the body. CBD and delta-9 THC, no comparison. I mean, they are completely different on how they act. And that worries me because people have asked me with these others, delta P THC, delta 8 THC, which has just a minor bonding change too, what impacts do we expect both acute and chronic? And I can't predict. I can't extrapolate from all the good research that's been done from delta-9 THC and say that delta P or delta 10 will be exactly the same. They may not. And some of these may have much more detrimental effects on the human body. And we won't know for decades, if at all, because they're rapidly changing. The Agricultural Improvement Act of 2018, also known as the Farm Bill. This was a federal change that allowed the cannabis plant to be depicted in one of two ways. One would be less than 0.3% delta-9 THC would be known as hemp. If it's greater than 0.3% delta-9 THC, then it's known as marijuana. Realizing also, and I'll have another slide about this, that marijuana, what people are smoking, has much higher delta-9 THC content than what was out there in the 1980s and 1990s. This also gets to be challenging because there's products being sold on the market that are claiming to be hemp because they're less than 0.3%, when in fact no one's doing quality control to indeed show that that is the case. It's also a federal and state conflict. As you're very well aware, Virginia has decriminalized, not fully legalized. And we have a federal government that is a Schedule 1, that is actually illegal. And this makes it very challenging right now. The other problem that I foresee is whether or not the federal government will ever decriminalize it. In order to decriminalize marijuana, the DEA is going to have to be shown that there's more evidence of benefit from marijuana than detriment. And I'll put out there, and this has come up with the Biden administration and the Trump administration that has looked at this, there's not enough evidence out there to state that there's more benefit than harm from marijuana and taking it off Schedule 1. And I'll be very curious to see in the future to see where these arguments go if we're doing evidence-based scientific medicine. Daily marijuana use. The good news is, if I had a slide up regarding the youth, we see in middle school and high school students a pretty significant drop in most substance use and misuse, such as alcohol and other drugs, except for marijuana, which is staying flat with some increase when decriminalization occurs. But we're also seeing a lot of vaping occurring in the youth. Now, if we look at those aged 19 to 30 and 35 to 50, this depicts Colorado. You can see there, when decriminalization occurs, there is typically a steady increase in use. And certainly we see this with the proliferation of vape stores and the sales of cannabis in the state occurring. Also remember, the average Delta-9 THC concentration in raw plant materials seized by the DEA has increased dramatically. When I was in high school, it was probably less than 3%. Now we're looking at it approaching 15%. So there's a much higher dose that people are obtaining by smoking marijuana than they were decades ago. The other thing is, when you buy a product that is a cannabinoid receptor agonist product, you don't know what you're getting. They may claim that it contains Delta-10, Delta-9, and at certain milligram concentrations, but no one is really doing good quality controls on those products. It's not like the alcohol industry. When you buy an alcoholic beverage, that has to be shown definitively that there's not contaminants, that there's alcohol of a certain percentage or proof. And that's not true of these products. And Michelle Peace from Virginia Commonwealth University, who I think very highly of, has done some very nice work pulling these products off the market and looking to see what they contain. And it is all over the place. When you think you're buying and are educated, and I'm buying a chocolate that has Delta-9 THC at 10 milligrams per chocolate square, all bets are off on whether or not that's truly 10 milligrams, or if you get 1,000 milligrams. You also don't know if you're getting other chemical substances. You don't know what other byproducts you're getting in the manufacturing process. And so, not products I want to take, and not products I want my family to take when I don't know quality control. If it was a perfect world, we'd have it such as the ABC stores, where everything was completely controlled, quality control, and nothing could be sold without knowing no contaminants. And the dosing that they're claiming is actually the dosing that's there. The other thing that's changed since decriminalization is the availability of things that are edible. So certainly marijuana was prolific in society and has been. There's a lot of people who are smoking it. And when you smoke it, it's absorbed rapidly. And the lungs are very good at bringing in THC. However, if you eat it, our gastrointestinal system is fairly slow, meaning that if you eat these products, you're going to have a delay in maximum impact of 1 to 3 hours potentially. This depends on the dose you got, what type of edible you ate, how much food is in your stomach. There's a number of factors that come into play when you're looking at this on whether or not that product you ate, when will the peak effect occur. Now, what I've found has been problematic with my students, for example, as well as others in Charlottesville, especially the youth. They take a gummy that has THC. They expect the impact to be similar to speed of smoking it. And when they don't get a clinical effect within 10 minutes, they figure the dose is small, so they eat another one, and then another one, and then another one, until they start to get a clinical effect that they can determine is from those gummies. Once that occurs, though, they overshoot, meaning that the dose then escalates more than what they wanted, and they start to get rapid heart rates, anxiety. They get misperceptions of reality, and that's when I see them in the emergency department, as they're exceedingly anxious with heart rates of 160, and they ends up getting a benzodiazepine such as midazolam to calm them down. We give it a number of hours for it to wear off, and then finally can discharge them. That's for adults. For toddlers who get into these products, especially when they look like candy, such as gummies, caramels, Skittles type products, I've had all types of patterns of what kids have eaten. They'll find a bag that they think is candy and eat the whole bag. And they actually tend to come in comatose. They're markedly sedate. A lot of times the parents or the babysitter or whoever was taking care of them don't know what they got into or don't want to relay what they got into. Subsequently, when you have an altered mental status toddler, they're going to get a large workup. They'll get a rapid MRI. They're going to get a lumbar puncture. They're going to get a number of labs. They're going to get an EEG. They get admitted to my hospital. And then after things wear off in 24 to 48 hours, you start to suspect something else is there. You may or may not have a positive drug screen, which we'll talk about later. And that's when we will do further analytical testing to try and determine exactly what they got into. And I have a large collection of children who've gotten into a variety of products that the drug screens never picked up. And I continue to warn everyone, be very careful in these cases. Please collect blood and urine early on them. Store that so that we can test it later to try and determine what exactly happened. The other interesting thing that's occurred with cannabis when you buy these products that are not illegal is if you get a product with a large dose and you have a psychotic break, who is responsible? Are you responsible? Is the company responsible? And this was really interesting. I followed this on the news. This California woman who fatally stabbed her boyfriend over 100 times avoided prison. And she had a psychotic break from eating a cannabis product that was not to be expected. And because it was not illegal, and because she was taking a product in good faith that didn't have maybe good quality control, she was found not guilty. Her psychotic break wore off. She became normal, had no recollection of the events of what occurred. And this is very rare to see. Typically, with substance use, you're responsible for your actions. But realize we're at a time right now, we have our citizens have no idea what they're getting. And if they have a psychotic break, that's a pretty disturbing that there's not going to be any ramifications for that, which may be the correct way to go. But it's also challenging because it puts society at risk too when these products don't have a quality control. And certainly civil litigation can occur against those companies. That's different than this. This occurred at Wintergreen. Dr. Moore was talking about, he has a place there, and Wintergreen is a beautiful place. It's a resort community, a lot of hiking. It's got skiing. And this occurred when a group of students who had graduated got together to celebrate graduation, and one of them did a hallucinogenic drug, had a bad trip, and ended up getting combative. The police were called. The officer on the right came to the scene, got in a scuffle with him, and that student was able to, while on drugs, get the officer's gun and actually shot and killed the officer. The question is he responsible for his actions? And he is. He willingly took a Schedule I drug that had adverse effects. It was illegal for him to take it, and he will go to jail for the rest of his life. Exceedingly sad when he wakes up the next day and realizes, I killed an officer, and will never see himself out of jail. And so it's a really challenging time when we take a look at these or try to educate youth the risks that may occur with these. Give you an example, psilocybin. With hallucinogenic drugs, there's legislation that is occurring throughout the United States This map is getting a little old. It's the best one I could find. I mainly wanted to depict that there were 2 states that passed bills to decriminalize psilocybin, a hallucinogenic mushroom. That is Oregon and Colorado. Washington, D.C. has also, and we're seeing a bleeding in of psilocybin into Virginia because D.C. is adjacent to us. The concern I have of what is out there right now, it used to be touted that these hallucinogenic agents were really dangerous and one to yourself and what you might do to others. And so there was a stigma of not using these, and we saw use decrease. However, as we're seeing studies done that are starting to advocate the use for post-traumatic stress disorder and other psychiatric conditions, there's less stigma. And I've heard some lectures by scientists who are working with these talking about the accolades of psilocybin and what it might be for benefit. And I think I'm fine as long as they can have disclaimers that, look, you shouldn't buy these products from the street. You don't know the dose. You don't know if you meet the indications for these. And instead, we have people who now think that can either self-treat or that I can do these hallucinogenic agents and they're safe to do. And I really caution people on this right now. And we're going to see a lot more as we see many more states decriminalize these drugs. For example, this occurred that some of you may have heard about in 2024. These shrooms products came out with adverse complications, and what the FDA started to do an investigation. And our team rapidly tested these and found actually these contained hallucinogenic products, including psilocybin. And that's really concerning that our public doesn't realize that they're actually getting hallucinogenic agents in these products directly. I also published in 2024, we looked at the Poison Center data. There has been a steady increase in psilocybin exposures to the poison centers over the last decade. My concern is that we're seeing this especially in the youth. And what is done in the decriminalization is they're stating these products will not be allowed to be sold to minors or people less than 21. However, we're seeing massive increases in those over 21, despite them stating they're not going to sell it to them. And so the youth, like with alcohol, are getting access to these products as they become decriminalized. We're seeing this with cannabis. We're seeing this with hallucinogenic agents. And this should not be a surprise to the public because we see this with alcohol also. There's many other products that are out there that can cause hallucinations. Many that are naturally occurring. If you look at the top middle, and I'll talk a little bit more about this, that's depicting kratom. There's a lot of changes occurring with kratom, which I want to talk about later. You can see Jimson weed in the upper left, something that historically has been used by our youth for hallucinations because it has scopolamine and atropine. You have mescaline in the upper right that comes from peyote. Nutmeg is closely related to mescaline with myristicin in it. If you eat 2 whole fresh cloves of nutmeg, you will actually get hallucinogenic effects. The left lower shows psilocybin, shows morning glory seeds of specific types. Heavenly blues have LSA that acts like LSD in them. You have Amanita muscaria on the right lower. We're seeing many products depicting Amanita muscaria. This is an Alice in Wonderland mushroom. It has muscimol and nibotenic acid in it. It's hallucinogenic, but it also causes seizures as a complication. And I've had a number of patients in my career who have taken that for hallucinations, but then seized and came into the hospitals. Psilocybin in the left middle, and then you have toad licking of certain types that have dimethyltryptamine in. And this is just a few things out there that can cause altered mental status or psychogenic effects. None of these will cause a positive drug screen. Changing gears, opioids. A lot of confusion out there in opioids, and there's confusion on the terminology, which gets important when it comes to the drug screens. Remember, narcotics can be depicted broadly. For example, legally, it depicts all illicit drugs. Medically, narcotic means kind of sleep-inducing. An opiate means that it's derived directly from the opium poppy. An opioid is a broader class and includes those things from the opium poppy, semi-synthetic opioids, and synthetic opioids. So when you look at the opium poppy, you have opium. From opium, you get morphine, codeine, and thebaine, 3 things that are in opium. When you look at this further, then what's derived from those, you have heroin, hydromorphone, hydrocodone, oxycodone. So you have the opiates above the line, which is what makes the opiate drug screen positive. And the reason it does, morphine, codeine, and heroin get metabolized to morphine and 6-glucuronide and morphine 3-glucuronide, which is what those opiate drug screens are looking for. On the bottom, you have the semi-synthetic opioids. So hydromorphone, hydrocodone, oxycodone are not going to cause drug screens to be positive. Very rare that they do. And so the opiates, the only thing I can guarantee with an opiate drug screen is morphine, codeine, or heroin. Then you have the synthetics, fentanyl, buprenorphine, methadone, meperidine, tramadol are all examples, and I'll give some more in a minute. But realize the drug screens will not turn positive with any of these synthetic agents. Their chemical structures are completely different. Now, there have been 4 waves in the opioid-related overdose deaths. This is coming from the National Center for Health Statistics, associated with the CDC. Wave 1 was a prescription drug problem. As you well know in Danville, this went on for years. As we started to crack down on the prescription drug problem, heroin made a comeback, and that was followed quickly by synthetics, such as fentanyl, which really has the market share right now. Currently, we are in the 4th wave, and this has pertinence to how we treat these patients. The 4th wave is characterized by stimulants mixed with opioids and an increase of comorbid mental health. And the reason this is significant, especially for me in my clinical practice, we're seeing naloxone flooding the market. Naloxone does have complications with it. We were never good about publishing about it. Everything from rapid reversal with pulmonary edema to adrenal surge, rapid withdrawal, and the unmasking of when they have a mixture of a stimulant with the opioids. In other words, if I took cocaine along with my fentanyl, I'm found sedate. Once you give naloxone, you're going to unmask the stimulant there, and you're going to have a very agitated, combative patient who's both in withdrawal from opioids and stimulated from the cocaine that's present. This is part of the reason why those of us who work in emergency medicine work in the most violent workplace in the United States. There's more verbal abuse and more physical abuse. This past year, I had one of my residents actually knocked out by a patient. And it's really challenging when we have the public, law enforcement are giving large doses of naloxone, not titrating it, not necessarily giving it for the right reasons, unmasking and having combative patients. EMS, emergency medicine, knows to titrate slowly. We only want our patients breathing. I don't need them fully awake. I don't need them talking to me. I just want my patients breathing. A calm, quiet patient is the best patient I can have. Now, you've also heard in the news, and I've talked on this in the news myself, we are seeing a decline in opioid-related deaths and the accidental deaths. And if you look at the fatal drug overdoses, the prediction for Virginia, lagging behind a bit in the data, we're waiting on the final data for 2024 to come out, and then 2025 the trends. But there's a significant drop, and this is good news. We knew at some point we had to plateau. It's been a really rough time period over the last 5 years, especially. But we're starting to see a decline. The question arises why, and we really don't know. It's certainly multifactorial. Certainly the federal government has worked to stop the trade of chemicals from China to the Mexican cartels to make fentanyl. Some people have claimed that a lot of our opioid users have died of overdose during the fentanyl epidemic. Some of it is our prevention effort. Some of it is naloxone that is saving lives in some very select cases. There's a number of reasons why this may be declining. We're actually seeing a decrease nationally in opioid-related calls to poison centers also. So it's not just deaths, it's also calls, and I'll be curious to see the emergency medicine data too. Now, fentanyl, certainly a drug that many of us use. I use it for conscious sedation and for pain control in select cases. It's developed in the 1960s, approved for medical use in 1968. Started to be seen by illicit drug users in the 1970s. And then clandestine labs started to change the formula. There's 144 known, and my last check, of fentanyl analogs that exist. I'm sure there's more that we just haven't yet depicted. And they all vary in their degree of potency, with the majority of them being more potent than fentanyl. We are also seeing fentanyl and other synthetic opioids being placed in counterfeit pills. The reason this is being done, if I'm a substance user, we know it's a dangerous time to be using heroin, or if I even know I'm getting fentanyl, because you don't really know what you get, and there's no quality control. The pharmaceutical industry, on the other hand, has exceedingly good quality control. So when I take and buy from my dealer an oxycodone that says it has 30 milligrams, I'm going to be pretty confident it has 30 milligrams and no other contaminants. The problem is they have a higher street value, which then makes it more economically incentivized for drug dealers to make counterfeit pills to make it look like it actually is oxycodone M30 to get more money for those, when in fact it contains fentanyl and other substances. And so those who are now buying what look to be pharmaceutical opioids actually have no idea what they're getting. And I've seen that in my practice. I actually had a UVA student 2 years ago who thought they got a Percocet 30 and actually got a counterfeit that had fentanyl. Unfortunately, survived that and was brought to the emergency department. But just realize these pills are out there, tablets primarily, that contain and look very much like authentic opioids from the pharmaceutical industry. The other thing to be aware of is it's not just fentanyl. There's other synthetic opioids starting to come into the market. The nitazines. I've published on this in the past. I have a lot of concerns about the nitazines. There's many different nitazines of varying potency. They do not make the drug screens positive, like fentanyl does not, unless you have a fentanyl screen. There's the U series. There's the MT45. There's the A series, and the list goes on. And we're finding these in samples. In fact, at the University of Virginia, we had one of our first nitazene cases, despite we've been seeing this around the nation. But now it's hit Charlottesville. So realize it isn't all about fentanyl. It's not all about others like heroin. There's other opioids now hitting the market. And just because the drug screen's negative does not mean it's not there and in your patient. The other thing that we saw as an example are other evolving substances. Now this one, tyneptine, was another sentinel event from my standpoint as a toxicologist. This was an antidepressant in Europe. It's under the brand name Stablon, for example. It's treated, however, in higher doses, it acts on the opioid receptor. This is being sold on the US as Zaza Red and Tyana Red. These products were actually sold in a vape shop 1 block from the office that I'm talking from right now. I'm at the Poison Center right now speaking to you. Just across the street, there's a vape shop under a Starbucks that sold Zaza Red that had tyneptine. It's also known as gas station dope. So gas stations around rural areas especially had this product that was being sold, and it's an opioid. And it's a opioid receptor agonist. This is one of the products I bought from the business across the street from us, which I frequent to see what's coming out on the market. They had 3 different products on the market at that time: Zaza White, Zaza Silver, and Zaza Red. When you look at the back of these bottles, these look like legitimate bottles. They're sealed. You can see it says tyneptine on it. It doesn't give you a dose. It just says proprietary blend 700 milligrams, just meaning that the stuff that's in the capsules weighs 700 milligrams, but you have no idea how much tyneptine you're getting. Also, one of them, Sovah Silver, had phenibut too, and I'll come back to talk about phenibut. Notice it states that it's to keep out of the reach of children. And then if you look at the back, it's not for sale for minors, 21 plus and only. And very nice of them to sell this right next to the university for research purposes only. And this is not meant for research. People knew exactly what they were buying when they bought this. They knew it had opioid effects. And no one was carding people who are less than 21. And why do I know this? My daughter, who I gave cash, who was less than 21 at this time, could easily buy these products with no one stopping her. No one was carding anybody. This included my students who go in these shops too. Thankfully, our legislature, who really have a big job to make sure these get banned as quick as possible, was able to get this as a scheduled agent in Virginia. And so tyneptine no longer is on the market. The Zaza Red product in Virginia is no longer tyneptine. It is now phenibut, which I'll come back to. They are quickly adapting. As soon as we make it Schedule 1 in Virginia, they will then change the product to another chemical. And they have an entire array of chemicals that they can put in these products as we try to ban these. Xylazine, you may also have heard about, is in with the opioids. Xylazine is another really interesting sentinel event. This has been around for a while too. This has been on since Bayer produced it in 1962. Is quickly noted to have extreme CNS effects because it crossed the blood-brain barrier as an antihypertensive agent. And it was found to work very well for animals. And it makes sense. This is the veterinarian dexmedetomidine. It is an alpha-2 agonist. It acts just like clonidine and like dexmedetomidine. It is potent. It crosses the blood-brain barrier very easily. It drops your blood pressure. It makes your heart rate slow. And it causes pinpoint pupils. And it causes sedation. It looks a lot like an opioid overdose. So they started to see xylazine in what was described as heroin. We see xylazine in our products in Charlottesville, in our patients' samples. So it is around Virginia. It's certainly in Charlottesville, and I'm sure it's in the Danville area too. This also has significance in that if I have a patient who's an opioid user, they're chronic, they take a product then that they bought from the street, it has xylazine in and an opioid, they're seen as depressed, EMS comes or police come and they give them naloxone. The naloxone will wake them up more from the opioid, but the xylazine may keep them sedated. And there's a danger there in something that we're seeing in our patients, that if I have a sedative on board like xylazine or bromazolam or other novel benzodiazepines, for example, that are found in these products, the patients remain sedate, but you actually give them naloxone in multiple doses, you will put them into opioid withdrawal. And part of opioid withdrawal is vomiting. So now I have a patient who is seen as depressed, not protecting their airway well, who just was induced to vomit because of all the naloxone we gave them. And so airway issues are also becoming a problem with our patients. They're vomiting, they're aspirating because of these other novel agents that are sedatives. Another one, phenibut. I mentioned the Zaza Red now has been switched to phenibut. Phenibut is a pharmaceutical medication that was made in Russia during the 1960s, the Soviet Union. It is a GABA B agonist. It acts exactly like baclofen. Amazingly, this is being sold as a nootropic. A nootropic is supposed to be brain health. It helps your brain. And I will put out there, baclofen does not make your brain think clearer, and neither does phenibut. Its use has increased over the last decade. We see this frequently. We see phenibut overdoses. We also see phenibut withdrawal. You can imagine those of you who use baclofen, if I have someone chronically on baclofen and stop it, they will go into baclofen withdrawal causing altered mental status, causing seizures, causing tachycardia and hypertension. Phenibut does the same thing. And then the phenibut withdrawal patients that we see in our practice, they get treated with baclofen. You need another GABA B agonist to treat that. I've advocated to our AG's office of the state, this needs to be removed. There's no reason for a pharmaceutical that came from the previous Soviet Union to be sold in our vape shops to youth and to adults, and especially when we're seeing the complications that we're seeing in our own clinical practices. But again, just pretty amazing that these products are making the market. What else is out there? We put out monthly a thing called Tox Talks that we try to depict to our professional population out there in Virginia what's hitting the market. And the thing that has recently hit is 7-hydroxymetragenine. We're finding it all throughout the vape shops, tablets, there's drinks. Some of you may have heard, for example, the news had it on recently that the alcohol industry is up in arms because the new generation is drinking less. In fact, if they look and extrapolate with the new generation and how little they're drinking, the alcohol industry is going to have problems in the future. As a toxicologist, I think that's good. However, it's being replaced by other drinks. And at the University of Virginia, our campus is called Browns. We are finding all kinds of products that are being sold right next to Grounds on Main Street. This feel-free product is a combination of kratom, 7-hydroxymetragenine, as well as kava. And for those of you who know kava, kava is a plant-derived that has kava lactones that actually act on the GABA receptor. In other words, they're selling drinks, this feel-free drink that have 7-hydroxymetragenine that comes from kratom that acts at the opioid receptor, and they're selling and they're mixing it with a plant that actually acts like a benzodiazepine. And subsequently, this drink, hard to know exactly how much is in there because everything in toxicology is about dose, but they're giving a product, advocating a product that has opioid and benzodiazepine type properties that people are drinking instead of alcohol. And these are not cheap, by the way. So what else can I find? Just before the University of Virginia started their academic year, the question arose, what are these shops selling that are right directly across the street or less than 1,000 feet from Grounds, our campus? And there are 4 shops that we went into. I actually got together with my fellows. We have 4 fellows in toxicology. It's a 2-year fellowship. We had 2 first-year fellows and 2 second-year fellows. I gave cash to them. My epidemiologist came along with. We divided, and we went and visited the shops to see what we could buy. Now, what's intriguing to me is when you go in these vape shops at my age, they're not going to show me things that are unique. I can see what I can see. But when the youth go in, some of my fellows, there are things behind the counter that they're trying to sell. So again, some kind of nefarious behavior that occurs in some of these shops. What do we find? Banging mushroom gummies, grapple. If you look at this, not cheap, $39.98, and it's a USA hemp product and maybe mushrooms based on what they're depicting, but not clear, proprietary. University, a class above, only for the University of Virginia would they do this. This has THCA, the active THC when you smoke it. So this is in a vape liquids. So I can vape THC directly. THCP, I mentioned there's other Delta products out there, and this one has THCP and CBD9A reportedly. You can see that they actually have a filter on there. They have it already as a joint form, and you can smoke these. Field Trip, playing off the 1960s. We got a VW van. We have mushrooms that are depicted as Amanita muscaria. I mentioned before that Amanita muscaria can cause hallucinations. It also can cause seizures. And again, we're seeing more and more of the Amanita products coming out That's because Amanita muscaria is not Schedule 1, neither state or federal. However, some of these products that we're testing do not have the potential of having psilocybin in, which is Schedule 1. Costola, the soda, has 2 milligrams of delta 9 THC. They're trying to keep this less than the 0.3% by the farm bill that I mentioned earlier. If it's less than 0.3%, then it's a hemp-derived product. This has delta 9 THC, and you can drink a soda directly. And what I'm finding in some of the shops around our campus, putting these products in the coolers along with other sodas, teas, and drinks that are already chilled for the students and others to buy. You have mushroom vapes, psychedelic. This reportedly has Amanita muscaria mushrooms in it to vape directly. We have THC gummies, 20 milligrams per gummy, sour apple. These are dangerous again for young kids. If this gets open, they smell them and it smells good. Again, not cheap. You're talking products that cost quite a bit when you start adding it up. All right, with all of that, all these substances, just a taste of what's out there. What about the drug screens, which we're relying on for clinical practice? To understand the drug screens, we have to go back to the 1980s. In the 1980s, Ronald Reagan was president. Ronald Reagan made an executive order when the war on drugs was occurring that all federal employees would be drug tested. And this was derived, for those of you who are old enough to remember, when the Nimitz aircraft carrier had a crash that occurred, and when they did the autopsies of the flight crews that were killed, they found a large number of them actually had cannabis on them. Federal government, this was legislated by executive order, that then rolled out to many other industries, including universities, to drug test. Now, in the 1980s, the 5 drugs that were tested for on urine drug screens were what was available on the street corner. In other words, if I was going to look to do a drug, I had to find the dealer who's on this corner. I don't have the internet. I can't get things mailed to me. I don't have these vape shops. And so what were the 5 main drugs in society at that time when these drug screens were developed? Marijuana. So they're looking for the metabolite of marijuana. Cocaine, looking for the metabolite of cocaine, benzoylecgonine. Opiates, looking for the metabolites of morphine, phencyclidine, and amphetamines. Amphetamines is a broad class, and remember again, opioids, heroin gets metabolized to morphine, which was the main substance being used in the 1980s. In fact, when I was in Detroit, certainly that was when the height of the crack epidemic and heroin epidemic. And I saw a lot of patients as a student who had the complications as well as HIV complications at that time. The Federal Register talks about when they do analysis, what is the cutoff on the drug screen? So just because a drug screen is negative does not necessarily mean it's not there. It just means it's below that cutoff that was set by the Federal Register. So the drug screens, antibodies to detect the presence of drugs, the urine drug screens, the results are quick, and that's why we tend to use these in practice. However, the gold standard is going to be mass spec. It's either GC mass spec or LC tandem mass spec. A number of different ways you can do analytics. We're fortunate again at the University of Virginia because we actually do confirm all of our screens with mass spec. Our drug screen at the University of Virginia is depicted here. Amphetamines, right, part of the night of 5. We got opiates, again, looking for morphine metabolites. We have PCP, and we have cocaine. As time went on, because of barbiturates and benzodiazepines, those were added to many drug screens. But remember, when those immunoassays were made for benzodiazepines, they were looking for byproducts of diazepam, like we have oxazepam, tonazepam, we have diazepam, Valium. It's not looking for other benzodiazepines. And so there's a number of other benzodiazepines that actually will not make the benzodiazepine screen positive. There's one from Russia called a Tazolam that we have seen in the United States. That will not make the screen positive. There's other barbiturates too that may not make those screens positive. You also notice on our screen, because they're semi-synthetic or synthetic and don't make our opiate screen positive, we have screens for oxycodone, methadone, EDDP, which is a metabolite of methadone for our drug treatment programs, and fentanyl. However, our screen will not turn positive for novel opioids, such as the A series, the U series, the nitazines. Also doesn't turn positive for things such as tramadol. There's novel benzodiazepines, phenylbutyrylneptine, kratom, xylazine, nitrous oxide, synthetic cannabinoids. None of these will cause that screen to be positive. It'll look negative, even though I have a patient in front of me that I know is intoxicated. And the list goes on. There's multiple drugs out there and substances that will not make these screens positive. Can't stress enough, those of you, especially in the pediatric world, if you have a patient who comes in and you're going to be admitting them, they're altered, you're suspecting the drug's there, ask your lab to save the blood and the urine from when they first came in. That way you can later go back and test. I have a standing order at the University of Virginia Health System. When we get consulted for a case, I put the order in. They save all original blood and urine for me, so that we can test it at more sophisticated labs looking for substances. This has been pretty important for Child Protective Services when we find substances that aren't supposed to be there, just so that we can try and figure out what happened. Recently, I had a case of a child that came in with altered mental status and had a seizure. They initially had a drug screen that was positive for amphetamines. The mother was approached by a team other than ours, confronting them that she was a methamphetamine abuser and that she wasn't being honest with the team. However, our confirmation turned negative for amphetamines. And when we got consulted and talked to the mother, we found out she was on Wellbutrin. She had spilled her bupropion. She thought she had picked them all up and most likely missed one. When we tested her child with more sophisticated testing, we found the child was not positive for amphetamines or methamphetamines. The child was actually positive for bupropion, which can cause the amphetamine screen to be falsely positive. And so again, be careful with these screens and be careful on how you depict those screens to patients too. With that, please call us. I can't stress enough, the Blue Ridge Poison Center, we've worked with you for years. I've thoroughly enjoyed the relationship over the 26 years that I've been at the University of Virginia. We want to have the data. It's not just calling for help, but it's just to let us know, look, we just had a patient who came in with an opioid overdose, because if you call us and when the other hospitals around you are calling us, we may realize there's a new something on the market that's causing a lot of people to overdose. Or there's something else that's in the environment that you don't know what it is. A new drug that you've never heard of. Call us. We might know of it. If we don't, we'll research it for you so you don't waste your time, and we'll find out what it is and get back to you. But that data comes in again and helps us to be able to better inform our legislators, better inform the federal government as to what are the risks to society and to our patients and our citizens of Virginia. What you're seeing depicted there is our newsletter that's meant for professionals. If you want to subscribe to it, please do. I try with my team to get newsletters out that are pertinent. We have one that's coming out next month that's pertaining to some of these screens that are being used, such as looking for fentanyl, which I think has a lot of issues with them. We just did some on some of the new drugs that are out there, 7-hydroxymetragenine we just did because we're seeing that start to really proliferate. But again, call us. We're happy to talk with you anytime. And with that, I will end and take any questions that you might have.
Mary, what do we have in the chat?
Well, Dr. Moore, we have a comment from Dr. Spillman. He said, as a Ahmed doc who has done MRO work beginning in the early 1980s, drug testing has been quite a journey. Dr. McIntosh says, good evening, everyone. Excellent presentation, Dr. Holstage. Are there specific innovations that show promise in overcoming the limitations of traditional urine drug screens? Thank you.
Yeah, in a perfect world, those are great questions. And I commend those of you who are doing MRO work. Very challenging time, especially in the occupational realm. I talk to a lot of industries. Can imagine if I am responsible for the trucking industry, I've had some patients in my clinic, you just can't make this up, who are pilots, commercial pilots who are using substances, because they're very smart. They know how to beat these drug screens. We need to abandon the old immunoassays. I'm going to put that out there. We have got to put money into better technology. And quite frankly, there is rapid technology out there with portable mass specs. I'm amazed that I recently visited our hazmat team. Our hazmat teams are getting money for portable mass specs. I can look for weapons of mass destruction and other chemicals by putting samples into it. We should have this similarly, and we should have this around the state at various hospitals like Danville, so you know exactly what's coming in. I can then, with working with that data, we can try to get these substances off that much faster. Our patients will tell us one thing, I did heroin, when in fact they are actually doing multiple other substances. So yes, I do think there is a potential. We need to put the investment in more mass specs throughout the Commonwealth to be able to detect these more rapidly. That's the future.
Okay, Dr. Spellman also said, thank you for highlighting toxin and all the facts and fallacies of drug testing. That's all that we have in the chat. Does anybody have a question?
Yeah, Dr. Graham, Dr. David Graham is raised his
Yes.
hand to speak up. Please, David.
Thank you. Thank you for an excellent talk. These talks I always find to be both fascinating and frightening. My question for you is, for most of these synthetic designer drugs, as far as you know, are most of these labs in the United States, or are they coming in from the outside?
Yeah, great question. Depends on what we're talking about. So many are in other countries. China, it's a national security issue for us in the United States. China learned from the Opium Wars, right? They lost Hong
Yes.
Kong. The Western civilization, Britain especially, addicted their population. I see it as a national security threat. There's other countries allowing these drugs to be produced and going to Western civilization where money is, that's causing major havoc. And that's where you're seeing the federal government actually talking with countries like China saying, look, this has to stop, or the precursor chemicals must be stopped going to the Mexican cartels who are making these substances. And so it's both. We do see it in the United States too. If it's not Schedule 1, these companies can make it. They're rapid in how they kind of emerge and then disappear. Pretty hard to sue them. So challenges with the DEA. So it's a great question. Some in the United States, some from, I would say, countries who are not looking out for the best interest of the United States or other Western societies. And it is a depressing topic. I mean, and I do worry. I think one of the wildest times we've seen is the 1960s, but I do worry we're going back to that with so much of the decriminalization that's going. That's a bigger concern from my standpoint right now. Watch the hallucinogenic agents. The decriminalization there, I have a lot of concern, especially with my collegiate population.
Other questions or comments? Mary, anything else in the chat?
If I could add one more question, you mentioned these vape shops quite a bit. What is the oversight for these shops selling vape and hemp and other products?
Yeah, David, it's a great question. I get confused at this too. You have the Consumer Product Safety Administration, you have the DEA, we have our own federal and state. And I agree with you, it is confusing. The vape shops have different laws than, for example, some of the, my understanding is some of the food stores and other places. That's why we're seeing a lot of them coming out of the vape shops. And then it's a question of who really does the quality control. Now, certainly if we have an outbreak where a lot of people are having detrimental effects, they go back and test, or we test, and we tell the government, yes, they will shut those down and go after those vape shops. You may have seen the governor's office just had a report out this last week. They had a major, I don't know what you would call it, but a major incursion into these shops, pulling products and closing them down. And I'd love to see more of that occurring because it is, I mean, it's really problematic when I can go across the street from my office at the Poison Center adjacent to my university and find pharmaceutical chemicals that are being sold as research chemicals.
Right.
That is just ridiculous. And as a society, we just sort of tolerate this anymore. So I would love to see us get, as we look at true legalization of some of these, really get tight controls like we have with alcohol. Won't solve the problem, but at least people will know what they're getting. Right now, they don't even know what they're getting. The products, there's no quality control. So, but back to your question, the vape shops have different rules, and it's just a matter of who has the authority with a society that actually has a bit of an anti-police sentiment to begin with. So it's a challenging time.
Thank you.
Yep. And for those of you with children, you should worry. It's something to talk when you go home. I was always talking with my children. I have 6 kids. They are all adults now. People have asked me why they haven't gotten into substance use. We did not have a problem with alcohol or drugs, but it was real for them. They saw me going to the hospital all the time for these. So my kids actually had a healthy fear. It wasn't, they didn't see it as embellished. They would always ask me when I got home after got called into the hospital, what was it about? And a lot of times it was substance use.
Dr. Halsey, I assume that most community hospitals may not have readily available the mass spec. So the thing is, you get the urine and blood samples on admission, have them hold it, and it's sent out to a reference lab. Is that a correct general statement?
Yeah, Dr. Moore, thank you. Yes. What I would do is hold those samples. Feel free to call us. I'm happy, myself, my fellows of faculty, we'll be happy to talk you through it. NMS labs, Mayo labs, there's other, large labs that do testing for us too, because we're not CLIA certified to do some of these. I can do initial surveillance testing, but I still send them out to get these in the medical record. But yes, we will narrow the playing field, and then we can help to tell you what orders at, for example, NMS labs to send that out to that lab to be able to depict what's there. This comes up quite frequently in our pediatric toddler cases, as I mentioned.
And I guess the other, just to reiterate, if it's not obvious, the Poison Control Center is available to clinic situations also. You don't have, they don't just take ER calls. It's where many of us experience working with them. But if you're in a clinic with a patient and you're trying to consider ordering other things, you just need to talk to somebody about it. I'm sure they take those calls also. That is correct, isn't it?
Oh, correct. Yeah, no, we take them from everybody, the public, professionals, whether it's emergency department or the clinics. I would say the majority of the calls we get from hospitals is, pertains to the emergency department, but I get clinic calls on a routine basis too. And we're getting more and more calls about the drug screens because we're getting people who are coming into addiction clinics or people who are being treated for their addiction who are turning negative on their screens, but they know something else is there. That's been a routine call for us recently.
Right. Any other questions or comments from folks on the call tonight? This has been a great program. I knew this would be a great program. This is such a timely thing, and there's
Dr.
really
Moore?
no rush and get this. Yes, ma'am.
Sorry, it's Dr. Austin Lipham. I can say well before I was a mother, but now especially that I am a mother, I just save the poison control phone number in my cell phone because stuff happens. But I recommend it to my parents that I have encountered that are using substances just to make sure that they are protected as much as it can be.
Dr. Austin, thank you. No, we're trying to get that with our public too, to use it. One of the things that we've seen is a decline in public calls related to pediatrics. And my biggest concern with that decline is they're using, Google searches, which we know can give you a false sense of security, and they may not go to the hospital. 90% of the calls we get at the Poison Center when they talk to us, we're able to keep at home. But that 10% is what worries me. And I'm worried that with the decrease in public calls, they're actually searching themselves, and that has its own problems.
Hmm.
The new generation doesn't like to talk to people.
I'd rather keep clicking
Yep.
or flipping, as they used to say on TV.
We're
Any
trying.
other questions?
Yep.
Any other questions or comments from anyone on the call? This is your chance. I will tell you that Dr. Holstead will be back with us in 2 weeks. So if something comes up, I know he welcomes your calling him at UVA or going to their website where you can email or whatever to them. But he will be back in 2 weeks, and we'll do Envenomated talks. Other than that, let me just thank you again. Excellent program. Very much. Thanks for your time, Dr. Holstead, and coming this evening and doing this. I hope everyone else on the call will be with us next Thursday night when Dr. Bowen from Wake Forest will talk about diabetic nephropathy and hopefully how we can better prevent and manage that. So otherwise, thank you so much for being with us. It's been a privilege and pleasure. We look forward to seeing you back in a week. Take care and good evening. Bye-bye.
Thanks, everybody.
Thank you.